How's that? Still presenter mode?
No, that's right.
Okay, it's correct. Okay, I've never can figure out how to avoid the presenter mode on this. Okay, so yes, I'm happy to be back here again to provide an update about faculty teaching performance in our department. And really, this is sort of going to be a summary as well of the last 4 years of this program. And essentially, we'll go through just some quick updates about the methodology of the evaluation process, particularly for some of our new faculty who are going to be getting started into receiving evaluations. We'll talk a little bit about the trends and data analysis over the last couple of years. And then we'll end off with just a few insights from the recent peer review that we received on this in the process of getting this published in JNS in the next month or two. It should be out hopefully. So the instrument that we're using here is called SetQ System of Evaluation of Teaching Qualities. It's a 31-item internationally validated questionnaire that provides both written feedback, so qualitative feedback from trainees, as well as quantitative feedback on 7 domains of teaching performance that have been established and kind of came out originally out of the Stanford faculty development program and kind of morphed into SetQ, which has been applied kind of throughout Europe in many of their programs, both medical and surgical programs. So the 7 domains that are looked at here are the learning climate, the professional attitude of the faculty, learner-centeredness, evaluation of residents, giving feedback. There's a section on professional practice management, which just focuses on whether some of these interpersonal skills and practice management skills are sort of being addressed in teaching sessions. It wasn't originally part of the original domains, but it was added in sort of the latest iteration of this SetQ, as well as role modeling, both as a person as well as teacher and as a surgeon or medical practitioner. And then the quality feedback is designed to specifically solicit both positive and constructive feedback from trainees, and this is given verbatim back to the person being evaluated. So we've sort of spent a lot of time figuring out how to apply this into our department, which is quite large and across many different hospitals and encompasses different subdivisions. And currently, this is how it's done. We have the faculty MSH and Mount Sinai West and Morningside, which are separated, as well as Elmhurst. Neurocritical care is sort of addressed in a system-wide fashion. So no matter what site you're on, you're sort of grouped as neurocritical care faculty. And then the same goes for neuroendovascular. And this is just to sort of control sort of the burden on the people who are filling out these evaluations. It's a long list of 40 plus faculty. So the trainees select which sites they have been most active at the last 6 months, and those are the faculty that are presented to the trainee for evaluation. The cycle is every 6 months, and so far, we've been trying to specifically get every single ACGME resident to fill one of these out every 6 months. We have also pre-residency fellows filling out the evaluations, as well as all of the subspecialty fellows, neurosurgery, endovascular, as well as critical care. And so far, they haven't really been, I would say, mandatory in the sense that I go and specifically find each individual and ask them to fill this out. But I think that, as we'll see, I think this is going to be more important as the trainees increase in number and faculty increase in number in order to sustain the appropriate level of data that we want coming out of the trainees. So the threshold is really, if the trainee had any interaction with an attending at least once a month for the last 6 months, we ask them that this is sufficient contact to be able to generate fill one of these surveys out. And there is a threshold for the number of data points that has to be collected for each faculty in order to generate a report, and that's 124 data points, which is approximately 4 completed surveys. And the idea is that we want to preserve, balance a few things, preserve the anonymity of the residents and the other trainees that are filling this out, to really preserve the integrity of the data, and also balance this against faculty receiving timely feedback. And we don't want a situation where faculty receives only one report every 1 or 2 years. Doesn't really give them the opportunity to really change and improve specific areas. And then we have set standards in terms of expected performance. So, the entire survey, you can get a maximum quantitative score of 220. We've set that the minimum expectation for faculty is to get a 190. And if you're scoring above 210, it's considered an excellent teacher. And one thing that we've kind of added in the last cycle has been sort of an added emphasis on surgical teaching actually in the OR. And, we're looking more specifically at a subset of the questions listed here that kind of focus more precisely on this issue. So question 7, for example, actually teaching surgical skills, taking the time to teach surgical skills in the operating room to the trainees, stating learning goals for the session in the OR that the resident's learning in, reconciling these expectations for what's going to be happening in that session, providing appropriate responsibility based on their ability in the operating room, and then giving the feedback. So evaluating exactly how the resident is performing in real time, and providing constructive criticism that the resident or trainee can take home with them and improve for the next time. And so this subscale is scored out of 42. And again, we're setting minimum expectations for that for surgical faculty who have been a member of the faculty full-time for more than 2 years. And this is what comes out on the other end for the faculty. So it's a pretty detailed report here listing a lot of numbers, but essentially at the top here, we have all of the domains listed each question, and the Z-score is really a measure of how the faculty member is doing relative to the entire department. So positive scores indicate that you're a standard deviation or however many standard deviations above the mean, negative scores being the opposite. And then you have also the raw score, which is what's used to compute the actual summative score out of 220. So each domain, except for the last domain, which is sort of the overall performance domain, is out of 7, and that adds up to 220 for the total score. And then we've added this extra column beside it there to give the surgical teaching subscore. And then we see so at the bottom here, the layout in graphical format, which uses the Z-scores. So, faculty will look at this and say, oh, I'm doing poorly, in some areas, but it's actually really relative performance. So if the mean is high for a particular domain, you'll see, it's expected that there's going to be negative values on the Z-scores. And some people, by definition, are going to be above or below the mean. But what we don't want to see is going like -2, -3 Z-scores, which indicates very wide degree of variance from the mean in certain areas. So in terms of how we've been doing in terms of data collection, I think it's, we were concerned because of the impact of, the pandemic and fewer cases and volume, at one point complete closure or elective cases. But in fact, I think that the data points have been holding pretty steady. We have at the top the number of surveys actually completed, which does fluctuate from cycle to cycle, mainly because of outgoing residents and trainees. It's a bit harder to get the feedback from graduating residents and trainees since they're gone. So we're trying to make some modifications that I'll get into about how to address that. In terms of completed reports, so these are reports where 124 data points were collected, and that's also holding pretty steady. And then where complete reports were not data points 124 was not reached, what happens is that becomes rolled over into the next cycle. Although the faculty member may receive qualitative feedback despite not having the quantitative feedback. So we call that a partial report. This is the overall trend over the last 8 cycles. So every single faculty that's evaluated here is graphed. And we see that overall, we see a kind of a narrowing, this kind of triangular trend where initially, the means were lower and variance was greater, but things are kind of narrowing above this dotted line, which is that 190 minimum expectation. So this overall looks pretty good in terms of what this, the data has been doing over the last 4 years overall. And then looking at this a little bit more closely, so each cycle, the distribution of scores, the raw scores are listed here in a violin plot, with the red being the mean and the distribution outlined in that shape. And it took about 3 to 4 cycles for us to really start to see a significant change in the mean and also the variance. So right around here in cycle 3 to 4, and things held steady for 4 or 5, 6, and then this is kind of when COVID started. Although it was a non-significant decrease here, we did see a drop in the mean as well as an increase in the variance. And then this most recent cycle, again, not a significant change, but again, we're kind of back to where we were in line with cycles 4, 5, and 6. And then this is another way of looking at the disparity in terms of performance in the faculty. And again, we've seen that there was a sort of a tightening in that disparity over time, with fewer faculty really being in this red zone where you have more than 20 items on the survey in performing more than 1 standard deviation below the mean. So that's what the red. And then green is where you're less than 5 of your items in the total survey are below that threshold. So overall, I think, again, there's improvement in that disparity, although it seems to be maybe plateauing here. So we'll have to see how things go for the next couple of cycles where how that trends out. So looking at all data across all cycles, we're looking at here what kind of predicts how well faculty are improving from cycle to cycle. And so what this is a correlation between performance on each individual item and how much improvement there was from cycle to cycle in the summative overall score. And I mentioned this before, but it's sort of every time we add more data to this, it kind of strengthens the conclusion that it's really evaluating and providing the feedback in real time to the resident or trainee that's really what they are using to kind of really judge overall performance. So are you asking residents in the OR some anatomy questions? Are you trying to get at their reasoning skills in terms of planning the case? Are you questioning them and eliciting, providing feedback about how they're attempting to address problems and issues that arise during the case? So that's all kind of evaluation of analytical abilities and feedback. The other components are reconciling learning expectations. So we get comments a lot where faculty are criticized for not for not, although they're teaching, they're not really providing what's maybe the expected level of responsibility that the trainee or resident feels that they're capable of doing in a particular case. So it's really the ability of the faculty to dynamically respond and adjust their teaching to cater to the level of ability of the resident or trainee. And looking just at the mean scores, looking at how much those raw scores have actually improved over the entire 8 cycles of the evaluation, what we have here is sort of a area under the curve for each item on the survey. And we can kind of interpret this as, these are areas where, faculty over time have tended to provide a little bit more attention to on the survey. And I think that all of this is because, professional practice management really started off kind of at the bottom. They tended to be the lowest scored domains. And I think that the fact that they're now the most improved speaks to the issue that these topics are being addressed more frequently. And then in terms of variance, so where we have seen the more uniformity, in terms of quality of teaching, has been bedside teaching, especially for the faculty who are non-surgeons, as well as teaching surgical skills in real time in the operating room. And then I just want to briefly address least improved items. So not necessarily to say that this is where we're doing poorly, but it's where there has been, maybe the least amount of change. And it could be because some of these items were generally in a good range to start with at the beginning of the cycles. But listening attentively to residents, and also professional and respect towards residents. And there's still quite a large relative degree of variance in how well practice management and professionalism is being addressed overall. Although the scores have been improving, it may only be that certain faculty are really trying to address these issues specifically in their teaching sessions. Okay, and then we've done a multivariate analysis on the overall data from all 8 cycles. And what this is looking at is how well these various independent variables, so the attending characteristics, predict whether the average summative score is high or low compared to the mean over the entire 8 cycles. And the only things that have, and we saw that this started to become significant maybe in cycle 6, but the p-values have kind of stayed in their significant range. But rank, so this one here refers to assistant professors compared to associate or full professors, tending to score higher in terms of summative score. Site, so and this is just barely significant, and I think this actually could change in the future as faculty are kind of distributed differently over the different hospital systems. But traditionally, the main hospital has been the one where teaching scores have been higher. And then the third one here, which is 0.01 p-value, getting a report every cycle. So this really reflects how much contact the faculty member has and how many evaluations they actually receive. So there are some faculty that receive consistently well over 200 data points per cycle, and it's these that tend to have higher scores as well. Okay, so a little bit about outcomes here. This was kind of an important point.
Do you want to hypothesize as to why some of these trends are being observed?
I think a lot of it does have to do with contact frequency. So it's possible that faculty who are taking more call, doing more cases in the operating room, have a higher volume and just see the residents more because they're doing more cases, tend to receive these higher values. And it could be because they really are taking more time and have more time with residents to teach in the operating room. But I would like to hear what the residents think about this too. I don't know if there's any of that.
Like to as well. The other question is that particular value controlled for operative volume? Because it may be an epiphenomenon.
Yeah, no, I haven't specifically
Right.
been dividing or subdividing into strata based on operative volume. Although in a different analysis that's not included here, the faculty that are evaluated less, so they get like fewer than 124 data points, and they get more partial reports. There's not a significant difference in terms of the average performance.
I see.
Yeah. So I think it has something to do with the volume, but also rank. We think it could be maybe that assistant professors are closer to their own training and maybe are attuned to some of the challenges they faced as residents and can kind of translate that perhaps a little bit more easily. Whereas over time you may lose that perspective, and maybe less apt to kind of adjust your teaching to suit various training levels.
You gonna have time to discuss this with the residents, because I'd love to get their input on this.
Yeah, I'll leave some time at the end here, and would love to have a separate discussion too. Okay, so just moving on in terms of outcomes, as this was an important point that came up during our peer review. Does any of this translate into improved educational outcomes for residents and trainees? So the easiest and most readily available data that we had was the primary examination scores over the last. We went back about 9 years here. So we have an epoch. One here is 2015 to 2017. So this predates the institution of SetQ in the department, and then the recent epoch is 2018 to 2020. So there is a marginally significant difference here in the mean, and these are adjusted scores, so they're normalized so that you can do this comparison. One important point that came up was, well, maybe it's just because the residents, that we're getting are just higher quality coming out of medical school, and they do better on tests. But in fact, the USMLE Step 1 scores are the same for all residents taking the primary examination in each of these epochs. So I think this really is an improvement that we see, whether it's all due to having this evaluation. I mean, it's probably just one of the many factors that have gone into, changes in our entire program over the last 5 to 10 years. This is the ACGME survey. So, the ACGME resident survey does address some of the similar things to SetQ, but is kind of directed more at the program rather than individual faculty. So I would say it's not really a truly orthogonal outcome measure, but residents may feel that they are more free to criticize, on these surveys, since it will not go back to any individual faculty member. And this is sort of the overall trend here in each of the 8 different items on the survey that kind of address similar topics. So is there sufficient supervision? Is there the opportunity to evaluate faculty? Do the faculty seem interested, et cetera? And it's kind of up and down, but aggregating the data again into 2 epochs and looking at how much our results differ from the national mean, which is the benchmark. We see that prior to this SetQ, we were at sort of the national mean, whereas in the latest epoch, there has been a pretty significant increase in the scores, and it's driven by this sort of peak that we had in late 2017, 2018, 2019, where the surveys were were fairly new comparatively. And then looking at the faculty survey, so on the flip side, there are a few items on the ACGME survey that faculty fill out that address satisfaction with faculty development, interest in education, and satisfaction with the feedback that faculty get from their peers as well as trainees. And this is a little bit more, and not clear. There's not really a significant difference in the two epochs, although there's a sort of downtrend that we've seen recently and that we've discussed separately. And I think Raj and Chris may be trying to address in a separate process. But yeah, there has been some reduction recently in those scores that has not crossed the threshold of significance. And we did do a self-evaluation of faculty back in cycle 6. So I think this is maybe time to update this. But this self-evaluation for faculty addressed whether they feel that they are satisfied with the feedback and whether they feel that this whole program has been useful in helping them improve teaching performance. And everyone pretty much agreed that it has been, but there could be changes that maybe the pandemic has also been a part of that are playing into the recent downtrend that we need to maybe look more into. Okay, another comment that we got is, well, what isn't this just a beauty contest? So what makes us think that this is not something that is really just a popularity contest among the faculty, and maybe it's really more the personal relationships between faculty and trainees that are driving improvements as opposed to actual teaching performance. So, so to address this point, what we did was look at selected faculty who changed the most over the course of the 8 evaluation cycles. So either positively, and actually it was most of them were a positive direction of change, but also a few that were in a negative direction of change. And so we reanalyzed this subcohort of the entire group for what items predicted these fluctuations the most. And so on the top here, blue are those items. So those that improved or reduced in their performance the most seem to fluctuate most on these 3 items. So motivating the residents, clearly stating learning goals for the learning session, as well as being a role model in terms of being a surgeon or a physician. So this sort of goes counter to the idea that it's really just a popularity contest. There are some items on the survey, like being respectful, being approachable, that may have more to do with the personal relationship and kind of just personality factors. And these actually were kind of the lowest correlated with this particular subset of faculty that either improved or went the other direction. And then the other main point was, well, the improvement in ABNS written exam scores is nice, but really does this have anything to do with the evaluation program that we started? And were there other factors like changes in the curriculum, changes in the faculty, the structure of the program that really were the bigger factors? And I think there are multiple factors definitely at play here, but this kind of led us into taking a closer look into what happened when we first saw the change in performance between cycle 3 and 4, where we really saw things change. And at the same time, this is when the evaluations actually became a part of the faculty evaluation process more formally. So that's actually when we established that 190 minimum expectation. So we kind of look more at the changes that took place at that time period back in 2018. And the big factors driving that change in score, and this is just a measure of how much each question domain changed between 3 and 4 to result in that significant difference. It seemed to be more driven by, one was, this issue of professionalism, being respectful toward residents, being a role model as a person, but also preparing well for teaching presentations and talks. So this kind of gets at, the quality of maybe even didactics that, residents were receiving at that time. So prior to the first part of 2018 and the last part of 2018, there was definitely changes in the curriculum of the program. And that's kind of when we did see, I think, the start of spine conferences, for example, and maybe greater emphasis on surgical decision-making in some of the morning conferences that resulted in some of these improvements. So correlating this to actual performance by topic on the ABNS written examination, this is actually our scores from the residents compared to the national average in percentage points for each sub topic that's addressed on that. So this is neuroanatomy, neurobiology, pathology, imaging. This is clinical neurosurgery. Here's NS. NO is neurology, and F is like critical care and fundamentals. So looking at this more closely, we see sort of that overall improvement. I've overlaid here the actual cycles of evaluation. So we're looking kind of more closely at the period where we did see a change in the curriculum in terms of didactics between cycles 3 and 4. And that's where that occurred in relation to kind of the trend here in scores. And so if we just kind of zoom into this area and then normalize it, just so that beginning of 2018 is the baseline, and then we look at how 2019 and 2020 have done, we see that in terms of area under these curves, neuroanatomy, clinical neurosurgery come out on top. So we kind of use this as an argument to say that, many of the changes between cycles 3 and 4 seem to be driven by improved teaching presentations and didactics, and performance on the other end did seem to mirror this in terms of improved scores in surgical anatomy and clinical neurosurgery. So in terms of the next cycle, so cycle 9, a couple of things that we'll try to do here to ensure that we get good data is kind of a little bit of the shifting of the evaluation windows. So for graduating trainees, fellows, residents, PRFs, I shifted the window to a little bit earlier in June in order to try to catch them before they're checked out for their after graduating. But despite that, it's still been pretty thin in terms of getting data from this group. And then all other trainees, the evaluation window is going to be opening very soon. And in fact, I may open it this week. And I do want to encourage individual faculty. I can't alone chase down every single resident every time, and every PRF and every fellow across all the sites. So especially critical care, endovascular, and the non-ACG fellows that may be at the other sites, we would like to have faculty specifically ask these individuals to complete an evaluation for them. And the faculty generally know whether they have been receiving the threshold level of data, 124 data points, to know whether they may be in need of getting more evaluations in order to reach that threshold on the next cycle. So I would like to encourage those faculty to please talk to the fellows that you most work closely with to get an evaluation from them. And then on the other end, I want to make sure that the fellows and trainees and residents know that regardless, the data are all pooled. I don't even know who says what. All I get is like a anonymized timestamp, and I can tell who has done it, who hasn't, but that's the extent of what I can see. So I think this is hopefully some reassurance that trainees are feeling free to provide this feedback, honest feedback. And, I think faculty really value, especially the comments, and, it may be more difficult there to really anonymize things because sometimes faculty can tell just by what they have been written, which resident it might be. But this is something I kind of addressed briefly on a previous grand rounds in how to construct the feedback in such a way that it's at once generalized and can't really be tied to one person, but also constructive and useful for the faculty, kind of like giving a scenario or example that can be, you can alter the details, you can alter the situation, but use an example in your feedback to kind of prove a point or to impress a point upon a faculty member. So just to summarize this, and hopefully leave some time for comments, changes in methodology, we're increasing emphasis on surgical skills teaching in the operating room. There continue to be positive trends, but performance disparity may be plateauing. Part of this could be something to do with faculty satisfaction with the program and the quality of feedback they're receiving, although certainly the pandemic has kind of been a curveball here. I think, demonstrated in our response to our peer review critiques that these instruments are valid. They actually do measure what they tend to measure, which is teaching performance in the various relevant domains based on medical education theory. And I think there is a plausible link between when we started this program and actually outcomes on the other end in terms of trainee performance. But I think this is something that we definitely need to monitor further and think of ways to assess in more detail going forward. Thank you very much.
Very impressive.
Thank you.
Very impressive. Comments, questions from the residents?
Just a question, that we were mentioning before to the residents, what do they think about, some of these factors that were brought up in terms of evaluation analysis? I'd just like to hear one of the residents' perspectives on that, and especially, where that doesn't happen. If a session, the goals aren't stated, how much does that play into your impression of the quality of teaching that's taken place?
Well, a couple thoughts. First of all, thank you so much for doing this, Dr. Yong. I've definitely seen a noticeable change in the way we're taught from when I was an intern and junior resident compared to now. So definitely noticeable difference. But a couple of my thoughts were, do you take the teams into account? It's like if the resident is on the blue service with specific attendings or not, and the subsequent question is, do you take into account the roles that in which the residents interact with the attendings? So is the junior resident rounding with certain attendings and operating with others, or like, to go back to your point about the level of professorship correlation, some of the juniors may only be rounding with attendings but operating and rounding with others. So maybe that is a little bit more it creates a little bit better dynamic compared to if they're just rounding and not getting that operative time or staffing consults with specific attendings. So maybe one question would be to kind of dive into the role that specific residents have with those attendings. Is it surgical? Is it non-surgical? And maybe you can get some answers out of that.
Yeah, there definitely is literature out there, data out there that shows that roles do play, and also level of training plays a factor in terms of how faculty are evaluated. Junior residents, junior trainees tend to evaluate faculty differently than seniors and emphasize different things. Each domain, though, is sort of intended to be agnostic to that. So no matter what level you're at, the question asks, did you feel that you were evaluated? Did you feel that you were given constructive feedback? There aren't really specific questions that say, well, how much of the case did you do? Did you, were you able to get under the microscope? That type of thing. But yeah, it's definitely known that faculty are evaluated differently by trainees that are of different levels. So just because you're doing well with senior residents and teaching them, getting good scores from them, doesn't necessarily mean that you're getting good scores from the juniors. So I think faculty have to keep that in mind, that every interaction with a trainee, whether it's PRF to the chief resident, to kind of think about how you are, what you're teaching that individual, how you're teaching them. But it may not just be operative skills, but also physical examination skills, history taking skills. Making a point there, I think, to do that goes a long way.
Ray, can I make a comment for you?
Sure, Tamir.
First of all, thank you for doing this. I think I'm a perfect example of somebody who has really come to see the increasing value of this from compared to the beginning. And I think neurosurgeons, we tend to be people who like to do well on things. And when you don't do well on something, you kind of at first think that there's problems with the methodology or other things and so forth. But then you really can kind of look at it and realize, I mean, obviously it's very clear from all of the activities that the residents are very thirsty to learn. And I think sometimes we fall into habits about certain people doing certain roles. And I think by having so many dimensions, I think what I can say on a personal level is you kind of see what areas that you might have just assuming other people are covering, and you can do it yourself. So I think it's provided some real value in that area. So I guess my comment to you would be is it might be an interesting academic, in addition to the changes that you've identified, maybe to see if we can survey the faculty to see what changes they feel they have made in relation to that and how it correlates. So I think overall it's a very worthwhile process that has helped me and others. I will say that one thing that Kurt was alluding to in terms of the teams and exposure, one or two times I've felt that even when you make changes, sometimes it doesn't, there's some lagging effect on the improvements or the changes in the score. And I wonder if that's sometimes because people are grading people that they're not necessarily currently interacting with, although they may have had a very strongly positive or negative interaction in the past. And it may go even beyond the time you even see them because they're on a different site or a different place. So, I think somehow a subscore of the people who are, I know preserving anonymity is a very important part of this, but I think a subscore that kind of looks at the people that you actually have worked with, whether it's validating. I know you have they need to sort of interact with you once a month, and I assume that there's a good honesty with that, but there could be people who have a motivation to go beyond that. So, but overall, it's a fantastic program, and I think that it's improved our teaching. Yeah.
Let's get back to the residents. How important is and how difficult is the issue of anonymity here? I'm realizing now for the first time that there really is not a very, it's not mandatory to fill it out, and it's not 100% that people are filling it out. I assume that the anonymity is a really crucially important part of this. Travis? The reason I ask is if we want to give you time, I mean, this should not be too much additional work, right? We don't want this to be a burden. The last thing I want to do is fill out a form. It makes me want to fill out the form in a negative way because they're making me do more work to fill out another form. Is there something we could do that would take the time, give you the time to do this? Maybe if everyone did it at the same time, that would ensure more anonymity than tracking down laggards, right? Someone didn't do it, you realize they haven't filled it out, and you say you've got to go fill it out, then it's no longer as anonymous. Frank?
Yeah, maybe we could take one of the Wednesday teaching sessions for the juniors. It's an hour after grand rounds, and we could all fill it out at the same time.
Yeah. Jeff? JZ?
Yeah, that's a good idea. I think overall it's a wonderful initiative, but I think it's a two-way street too. So I think the more engaged the resident is, the more engaged the attending will be. And
Right.
You hear attending say it all the time. A resident's worth teaching if they're putting everything into it. So I think part of the reason the scores have improved as well is because I think overall resident engagement has been better.
Trevor, what are your thoughts?
I would agree with Jeff. I think that a large part of this is highlighting the importance of developing relationships. And I think that the relationships start early on as a junior when you're the ones that are rounding with the attendings. And I think understanding the importance of developing that is going to help, continue this very nice trajectory, I think, overall that we've seen in terms of increasing the teaching opportunities. That's also been, I think, something that over the last couple of years that I can say that Dr. Morgenstern, I know when he started to help with some of the academic stuff along with Dr. Hadjipanias, and we really restructured a lot of that Jeff Zimmering also was involved in last year.
Right.
I think that that was identified as a gap by this study of Dr. Yong's, and I think it made a significant improvement. So I think my thoughts would be that the relationships that are highlighted early on and developed is going to account for a lot of the positive change.
If I can also make a few comments, I think so. That's an excellent point, Trevor. And I think what we're seeing is the evolution of a complex learning environment. So first of all, Ray, I think these are extremely helpful. I mean, they're helpful for me personally. I think they're helpful for us as a group. Every program has some component now of resident-related feedback, and with you deal with, the restriction of work hours, when you have COVID in different areas of rotation, you start to put pressure on what I would call the learning environment. And I think we have a complex one. We have our PRFs, we have our APPs, we have everybody at different stages of learning. So then how does one construct an environment such that you have interaction and you have meaningful, impactful learning? And I think that's going to continue to be the challenge for us, as faculty over the next few years, is how do we keep that impact and that engagement as we continue to see the evolution of our training. So I think this type of feedback, Ray, is fantastic, honestly.
Halima, what are your thoughts?
I agree with Jeff and Trevor in that, I've only officially done one of these, but like I was here as a PRF and I saw like the change in the effort in conscious learning that has been made both at the level of residents as well as faculty. I know Dr. Shivastava has also like emphasized it several times where, we are now taking out more time to sort of like on that at didactics and like preparing for cases. So I think overall it has had a positive impact on our learning, and that is reflective in the overall results of this survey.
Something that was said, I can't remember who, that really does stick with me is that all of us continue to learn. We do focus on the residents, and this is, the resident survey, but it's a complex learning environment, as Raj said. We have to find a way to give access. I think access is a key part of this, to give access to all of the people who are in this environment. And I'm thinking right now about not just the residents, but also the APPs, nurse practitioners, physician assistants, and obviously our pre-residency fellows. It's hundreds of people who are involved in taking care of thousands of patients. And obviously I want the resident surveys to go well, and I want the residents to feel that you are getting the absolute best education in the world, if not the country. I don't think that's possible unless we can find a way to be conscious of giving access to everyone who's helping here. But this is such a great effort, and it's a little bit humbling because you see that, no matter how, I'm reminded of the Charlie Brown cartoon where, Charlie Brown walks through the ICU as a surgeon, and there's a little cloud where he's thinking how great he is, and you hear the thoughts of everyone he passes, and they're not so great. So we think that we're doing our best, but we're not always doing our best. And this survey is kind of opening up those little thought processes that other people have that we don't normally get to see. So This is a wonderful initiative. Any other comments?
Yeah, I'd like to comment that I found this extremely helpful for myself because when I'm engaging with a resident, I often think back to what that list is. And there are many things on that list that they're evaluating that I was not originally thinking as part of my interaction. And so it highlighted things to do in addition to the normal, this is the case and this is what we're doing. And then another thought is there any way to gather any objective data over time? I think that might strengthen, if possible, that might strengthen the longitudinal following of how the resident responses are changing and maybe the impact of various teaching styles are changing.
What do you have in mind?
I mean, it comes down ultimately to, I guess, do we have any objective measures of surgical performance? And does it seem like a resident is getting better shortly after an experience with a particular attending or on a certain service? So you can see teaching effect in an objective way. I know that's the ultimate challenge, and I don't think there's an answer to that. But.
Yeah, there may be some, objective way. Again, it's going to be pseudo-objective because, again, milestones, are still sort of a subjective process even. So, that's the process of faculty evaluating progress of residents. But is there potentially any more objective way of doing that? I think it's possible to think of something, but I think it would be quite a challenge in terms of implementing a tool kind of that's independent but also valid to assess.
Those scores, those board scores, you said it was only 0.049 significance, but that's probably because of variation. But the difference was 100 points on the board exam. Went from 300 to 400.
Yeah, below 300, to 400.
That is a very, that is very massive increase.
That's knowledge, but yeah, I mean, I guess it could be something like almost like an OSCE type of thing. If we had a standardized OSCE that evaluates or oral boards, which we do, but like a standard type of oral board examination where we can actually measure some of these things in house. That could certainly add to that.
I was imagining like you record the microscope performance. Each time there is a microscope performance, and then that's objectively scored. And we could come up with metrics of what would be quality microscope operation.
I mean, I will say that there's a lot of discussion nationwide, Chris, about exactly what you're talking about instituting various quantitative metrics for development and training. And different programs have different, some are so specific that they actually have point systems and they have sliding scales and they have weighted averages and so forth. I think one of the struggles I have with all these systems is you're essentially dealing with a small cohort. You're dealing, as I said, again, with various stages of learning. And then I feel like the more you try to quantify these things, you're adding on artificial variables. So I think it's almost ironic that we went from a system whereby, you would teach people with one-on-one and you move towards metrics, which sometimes seem in themselves artificial. So, my personal opinion is not to make the process a process itself, if that makes sense. But, I'm always open to other people's comments too. I mean, perhaps there's a better way than milestone for sure.
Is there a question on, do we ever ask the residents how comfortable they feel in their advanced microscopic surgical skills? I feel that is that the residents are highly able to self-assess their own skills under the microscope as to where they want to be and where they think they should be. It would obviously be a highly subjective response, but I'd be interested to talk with the residents further about this. If you'd be willing to answer such a question, could not be anonymous. I mean, it could be, but not as useful.
I have at
Because
times, made a point to kind of ask that question as sort of the briefing, the briefing before a case. And that could be an appropriate time where, you're working with a senior resident, you ask them, well, okay, we're going to be under the microscope for this case. What do you feel comfortable doing? What do you want to challenge yourself to try to do? And then, it may not be possible for every case, depending on how it goes. But then I take that and try to gear the microscope part to what the resident has stated. But that's a one-on-one thing. But it might be good to get also broader kind of group data to kind of share with everybody.
well, that's pretty good stuff.
Okay.